we have risk factors for running injuries. So Jason Tuori, physical therapist, runner, triathlete, injured guy, I happen to know. So he has lived this stuff. He's not just talking theoretically, although there'll be plenty of that too. Jason, why don't you take it away?
Great. Thank you, Adam, for putting this together, setting it up. So my name is Jason Tuori. Until very recently, I was a PT in the Ithaca area, working at a private practice, seeing primarily orthopedics, sports, treat a lot of runners. I'm a running coach and strength and conditioning coach as well. Recently relocated to Rochester to complete a sports residency. And so that's where I'm at now. And tonight I'm going to be talking about risk factors for running injuries. And as Adam indicated, these are some things that I do. Let's be real, this is really what I'm into. Do not have any conflict of interest. That would be nice to have one. So your typical objectives for a presentation, we're going to talk about identifying different types of risk factors for general running related injuries. And what's important about this is what we're talking about tonight are general running related injuries. So what are the common links between all running related injuries, not necessarily specific running related injuries. And then we need to recognize the limitations of where we're at in terms of our current knowledge of that, and practical solutions, question and answer. So what this means is we're going to talk about why we get hurt. We're going to talk about science, and we're going to answer questions because it's confusing. So running is a complex system. I like to put this slide out here in most presentations. And if we remember from our elementary biology, a complex system is a network of interacting variables that produces some unexpected results. And so what we see with running related injuries is that maybe some things that we might expect to happen don't necessarily happen because of all the moving parts. And some things that we don't expect to happen might happen also because of these relationships. And of course, this is the newest complex system in running, is how do we get our hands on a pair of Vaporflies? Is me the primary consumer down here. So what is a risk factor, I think is important to start with. Risk factors in research are going to be classified both as causal and non-causal, and that's going to be dependent on the way that the study was designed. So there's a certain type of research study design that can indicate that something is more of a causal risk factor, and there are other types of designs that are really only there to show association. And so a common example that I like to give is coffee consumption is associated with lung cancer. Now, nobody would really think that there's any plausibility that coffee causes lung cancer, but coffee might be associated with smoking a cigarette and drinking a cup of coffee. And therefore, by association or by proxy, this coffee consumption is now a risk factor for lung cancer. And so those associative risk factors don't really tell us a whole lot, and they're really not useful for us. And so that's why a lot of the research that's designed to identify risk factors is highest quality if it can generate something causal out of it. So we can categorize risk factors in a couple different ways: intrinsic and extrinsic. There's intrinsic would be the property. This is something that's within the runner. Oftentimes, it's not something that we're going to be able to change, but there are certain risk factors that we can modify that are intrinsic, and we'll talk very shortly after this about what's modifiable and what's non-modifiable. But our intrinsic risk factors that we're most commonly thinking about in terms of any sports injury are things like biological sex. Does one get injured more often than the other? Our age, muscle strength, our running technique, height and weight, running experience. So there are a lot of variables that could be considered intrinsic risk factors. And in a couple slides, we'll break down some of those and go into a little bit more detail about what might be associated with general running related injuries. And then we have our extrinsic risk factors, which are going to be external to the runner. So these are things like the environment that we're training in, like our training surface and terrain, our footwear, and our actual training loads, like our running volume and our running intensity are all extrinsic risk factors. So I think it's a lot more helpful to think about things through the modifiable and non-modifiable lens, because we can't modify the factors that we can't modify. So when we think about non-modifiable risk factors, and we'll get these out of the way first, there's a lot that have been studied, and there's only one that seems to be a common theme between all running related injuries, and that's a history of previous injury. And that history of previous injury doesn't necessarily mean that if you've had one specific running related injury in the past, then you are more likely to get that same one again. That oftentimes is the case. But a lot of studies also categorize this as if you have had one running related injury in the past, then that is a risk factor for developing another one in the future. And there's a lot of debate about what that actual relationship or explanation between that is. And that's, for the most part, currently unknown. There are a lot of theories on it that we can talk about later. But a lot of the other non-modifiable risk factors that we might think about oftentimes are age, sex, height, running experience, and other demographics like education, occupation, marital status, socioeconomic status, and number of children. And so all the studies that have looked at these factors have not shown a consistent association with general running related injuries and any real grouping of these factors. So say older age doesn't necessarily mean that you're more likely to get injured. More training experience doesn't necessarily mean that you're less likely to get injured. Now, we do know that novice runners get different types of injuries and maybe get injured at a slightly higher rate than experienced runners, but everybody's going to get some type of injury at some point if they're training. Now, our modifiable risk factors, there's one consistent modifiable risk factor for all running related injuries, and that would be the exposure to running. So you have to run in order to get a running related injury. Unfortunately, that's about where it stops. There are no other variables that seem to be a common link between all running related injuries. But the majority that have been studied are looking at, so your training volume or running distance. There's a lot of studies that have looked at runners that run for, they have really high weekly mileages. And some of these studies show that these runners are more likely to develop a running related injury. And there's been clusters of studies that show that this high mileage is actually protective for injury. So anytime that you see two of these conflicting results, that basically means that thing is not, it's not statistically significant as a risk factor if we're asking this certain question. Now, training intensity is the same way. Out of 20 studies that have looked at that, 8 have shown that runners that run at a higher intensity are more likely to get injured, and 10 have shown no association. There was a research group in the past that tried to stratify and say, do runners that run at higher intensity just get different types of injuries compared to runners that train at higher volumes? And that was also found to be insignificant. So at the moment, for general running related injuries, we can't necessarily say that somebody's training high volumes or training at high intensities that they're more likely to get injured. Now, it does seem like the how you get there might be the question. So if somebody is increasing their distance by a large margin sequentially week after week, that hasn't been studied too much. So as much as we kind of cling to the 10% rule as like a rule of thumb to increase our weekly mileage, recent systematic review of only 4 studies showed that there's really not much of a difference in injury rates if you increase a weekly distance by 10% compared to 30% of the previous week. Now, the major limitation there is that those studies were only looking at increments of 2 weeks. So if somebody just keeps doing that over and over, we would probably think that there has to be an upper limit at some point. So we do think, despite a lack of evidence that this spike in workload or change in training load is significant, that it still ends up being one of the things that plays into developing a running-related injury. Now, when it comes to other modifiable factors, we do see from a specific injury standpoint, I do want to talk about that, even though this is about general injuries. From the diet and hormones category, having a low dietary intake of calcium does seem to be linked to stress fracture development. The presence of taking oral contraceptives in young female runners seems to have a protective effect against stress fractures, and absent or regular menstruation seems to be a risk factor for developing bone stress injuries in young female runners. Other than that, there's conflicting evidence for our footwear studies, surface training, the surface and terrain that we're training on, stretching, warm-ups, cool downs, other psychological variables like behavior, training behavior, and personality traits. So initially thought that the type A personalities might see the higher spike in running related injuries, but several studies have actually shown that type B personalities also have shown high rates of running related injuries. So not really something that seems to be the factor there. I do want to talk about something that's modifiable that often gets talked about with running injuries, which is running biomechanics. And what we can say about all running related injuries is that there is no one biomechanical factor that is linked to all running related injuries. That doesn't mean that running biomechanics doesn't matter. So if I can give a few examples here of some things that we often think about. So foot strike is probably one of the most debated topics of, is this something that can reduce injury risk, or does a certain foot strike cause injury risk? Well, what a foot strike does is it just changes the stress in each stride that we're running. So if we're thinking that each stride of running is just sequentially loading the foot, the ankle, the knee, the hip, and the spine, we're just changing the pattern of where it's loading. We're not getting rid of anything if we're still keeping the same amount of training volume. So that would be why something like changing your foot strike pattern isn't going to stop you from getting injured. It might just change the type of injury that you get at some point. And really the same goes with the classic models of foot pronation or ankle pronation. There's a large prospective study in 2014 that showed that the runners that were injured most actually had kind of a moderate amount of pronation, but ones that pronated a lot and not that much at all were there were not as many injuries in those groups. So no logical conclusion from that would be we need to start pronating either a lot or a little and stay out of midline. It would be, this doesn't really seem to be a factor that's associated with all injuries. And with all of these, specific biomechanical things, that with specific injuries, they may be under consideration of something that we would want to change. But if our goal is to just reduce the risk of injury, and we're always more effective when we're trying to reduce general injuries versus a specific injury, because what's good for one specific injury might not be good for another one. So we would end up kind of just playing whack-a-mole, or robbing the poor to give to the poor, as I like to call it. So how is that all we know right now? Why haven't we gotten this right yet? Well, that's a good question. There's a couple of things about running literature that I do want to get into that are related to what we do know and why all of this is so hard to figure out. So here's what we do know. We know that the calf and the quad are responsible for producing and absorbing the most energy when it comes to running. So above all else, that's likely why we see that the most common running related injuries are kneecap pain and Achilles tendon pain. These are the muscles that the demand is highest. And if we're talking about any other muscle groups, we're probably overlooking these unless we've established that first. And so we'll keep in mind here that the quad and the calf have the most demand placed on them. And then we have a simple equation to run here. So if we have a runner whose cadence is 172 steps per minute, that means they're going to hit the ground 86 times per limb per minute in a given run. They're going to go for 30 minutes, and by 30 minutes, they've already hit the ground 2,500 times with each limb. I can't run a marathon in 2 hours and 23 minutes. I know that somebody can. Maybe somebody on this call can. Good on you. But this pretty much just goes to show that this cumulative load adds up really quickly. And if we think that each stride, say the ankle takes on anywhere between 4 and 8 times body weight, depending on the runner and depending on form, and the knee is somewhere between 2 and 3 times body weights. That's a lot of cumulative load from our training volume standpoint. So then when we think about the basics of what is an overuse injury or what is a training related injury, the vast majority of these running related injuries are not acute injuries, say for the sprain your ankle stepping off the curb. They're ones that just kind of came on insidiously after something had changed. And so as adaptable as human bodies are, the one thing that they really can't handle that well is a large period of change, or a large amount of change in a short period of time. And so this envelope of function model basically is that if we're floating around our envelope of function, maybe we're pushing a little bit past it or a little underneath it, we're going to be doing pretty well and we're going to be able to maintain. But if we far exceed it by doing something we're not used to doing, or if we just stop doing everything completely, then that envelope is going to shrink. And now that envelope is shrunk, the stuff that used to be previously easy to do or pretty doable is not doable, whether that's pain or dysfunction that's stopping that from happening. So it ends up being this load versus capacity model of your capacity is going to be your beer stein here, and your load is your Pilsner. So if we're asking our body to do more than we have the capability to do, that's essentially what a running related injury is. But we also know, thinking back to that complex systems model, that there's a lot of variables involved. It's not that simple. And the one problem as you get to all these different variables that interact with each other in this system of what produces a running related injury is that we don't know how each of those variables interact with each other. And so what a black box study, and most studies that are where the interest is we want to see what the injury outcome is, are black box in nature. And what black box means is we don't know what the actual mechanism is or how this stuff interacts, but we've got this starting point here and we're going to throw stuff at the wall and we're going to see what comes out afterwards. And I always think about this old episode of The Simpsons where Lisa becomes president and Homer is obsessed with finding Lincoln's gold. And so he just, he has this little scroll and it tells him how many paces to go. And he just starts at an arbitrary point and then he paces and then he starts digging in the middle of the White House. And so that's really what it's like. If you don't understand what the mechanism or the context is when you're investigating this stuff, then you're basically just throwing stuff at the wall to see what comes out. That's not how this works. So what do we think actually is in the box? This is the most recent model. This is a comical model that is developed to explain running related injuries, and it's pretty much the standard at this point. It's called the STAMP model of running related injuries. You're not supposed to be able to make out the text on this slide because this can't even fit onto a single slide. In the paper that it's on, it comes in its own side appendix. So this basically just shows these are all the interactions that are happening when it comes to why does somebody get injured, what are these risk factors, and what's the interaction between all of these things. And that is why we can't say that this one thing or these two things together are the reason that somebody got injured, or that we need to try to stop doing these things, otherwise we will get injured. And the last piece that I just want to talk about based on that are mediators and moderators. So a mediator is going to be something that explains the context of why we might think that something is a risk factor. So if I run 60 miles in a week, let's say for me, that's a risk factor for developing a running related injury. Now for somebody else, 60 miles in a week is not going to be a risk factor for developing a running related injury. So right there, that shows that there's a confliction between just base distance as being a risk factor. But the real reason why that might be a risk factor for me is that in my current training state, that's going to lead to an imbalance between stress and recovery. So there's going to be too much stress for my body and not enough time to recover. Whereas for somebody else, the stress recovery balance might be fine at 60 miles per week. Now, the difference with a moderator is the moderator is going to be something that influences the other variable. So if I'm running 60 miles a week, and let's say this is a good batch of training for me, it's otherwise not going to necessarily lead to a running related injury, but that 1 week that I hit 60 miles, I also didn't recover enough. So I was chronically sleep deprived, and that alone then was enough to moderate that and lead to a running related injury. Now say we get rid of that moderator there, maybe that running related injury doesn't happen because of the imbalance between stress and recovery. So with all of this, what should we worry about most? And here's the list. So whenever we're talking about humans and science, the human element can't be overlooked. So we have to listen to our body. And what that means for our training is there needs to be some recovery days, whether that's planned or unplanned. There needs to be some modification of workouts based on how we feel. It's really simple that all this stuff boils down to, if you don't feel really comfortable with what you're doing, then you need to reel back a little bit. Number 1B is going to be manage previous injuries. So if we can say that history of previous injury is a risk factor for future injury, and that's consistent among all running related injuries, then there's probably something to that whole previous injury thing, which means we need to really finish off our rehab when it comes to previous injuries. And Adam and I were talking the other day about what does it mean to really finish off and rehabbing an injury and then continue exercising it as well. Well, it has to be progressive. So if there's an area of somebody's body that they've had multiple injuries in the past, they really should consider doing some specific strength and conditioning work for it. And it should be difficult. It shouldn't be something where they just kind of go through the motions, because that's not how the body adapts. The body adapts to a stress that it's not used to gradually over time. So we do need to manage our previous injuries. We should avoid frequent spikes in training. And this is probably the one that's most intuitive, but least backed by evidence. But it's important to note that the absence of evidence doesn't equal the evidence of absence. So it very well it may be that frequent spikes in training are consistent for developing running related injuries. We just don't have enough evidence that says that yet. We don't have a whole lot that conflicts it, which means based on our physiology of how we adapt slowly, it's probably prudent that we just avoid these large decreases or increases in training load. And I think it's important to think about the decreases too, because there's different systems in our body that will de-adapt at different rates. So we know that our musculoskeletal system takes 6 to 8 weeks to build strength, but our aerobic capacity can change within 10 to 14 days. So that imbalance right there may also be a reason why sometimes we're going a little too fast, we're progressing a little too quickly, or when we've taken a few weeks off, we jump back into things, and there are certain aspects of running that don't quite feel right yet. So that frequent spike in training, we're talking about running volume and running intensity. And so volume may be the longest continuous run or frequency from days a week. And intensity could be just the pace that you're running or terrain, so elevation that we're running on. And number 1D is select a sustainable training plan. And this is going to be the one that is oftentimes a lot of guess and check for people, because you don't really know what's sustainable until you figure out what's not sustainable. We usually don't want people to figure that out, but it sometimes has to be the thing where you realize, okay, whether this is not working out for me because I keep getting injured, or it's not going to fit into my life schedule. We have to pick something where we can be consistent, because that's what distance running is. Distance running is just the consistency of training over the course of several years. And a lot of the studies on the elite marathon runners show that their training is an uninterrupted 7-year, 9-year, 11-year block of just getting long, slow distance running in. And there's a lot of coaching philosophies, and obviously there's going to be different runners training for different races, but there's a common theme. One that I particularly subscribe to from a coaching standpoint is the polarized training model, which basically says somewhere around 80% of your weekly mileage should just be slow and easy. And 20%, yeah, maybe you do some race pace work or different types of higher intensity stuff, or you also just run easy. There seems to be diminishing returns from a VO2 max and lactate threshold standpoint if we're pushing that 20% a little bit higher, which basically then means we're working harder, but we're not getting quite as much back from the return standpoint, and we're maybe pushing ourselves a little bit closer to injury because we're just training at higher intensities and higher volumes. So that's a rule of thumb. It's one method that works for some people. But what's sustainable is often we have to have easy days in there. That's, I think, the common theme that comes back over and over again. So that's the list. There's no one, I think, that's more important than the other. That's why they're all listed as number 1, A through D. And our take-home points are basically going to be that, we see these high injury rates in runners. They're very common, but they're going to be nearly impossible to figure out from a global standpoint because of all these factors involved. We do know more about some specific injuries compared to all running related injuries. But as I alluded to earlier, a prevention approach is most effective when we're looking globally as opposed to looking at things specifically, because then we end up just playing injury whack-a-mole if we're looking at specific injuries. We have to focus on what's modifiable. To me, there's no sense in worrying about certain structural things like somebody's bony alignment. It's all something that, with the right type of training load, that doesn't become an issue. We need to figure out what's easiest to change too. And certainly from the PT standpoint, this is something that always is just a kind of a recurring theme, is if you make small changes, you're going to be more successful overall in sticking to the plan. And focus on what yields the highest return for you. And if the answer was simple, I would not have a job and we wouldn't have injuries. So now we'll open it up for a Q&A.
All right. Thank you so much, Jason. Let's see. You can leave that up for a little bit so people can grab contact information, but we'll stop this screen sharing in a minute. So this is great. I mean, I really appreciated hearing that getting old isn't inherently mean I'm going to get injured more, and all of those kinds of things. Although I'm a little distressed to learn that all the various injuries in the past may predispose me to more as we go. So that's a little bit stressing too. We talked about this a little bit before too, but if you had to say one thing that people aren't doing enough of to prevent injuries, what would it be? And I know what I'm going to think you're going to say, but we'll see what you're going to say first.
I might surprise you and say, uh, keep keep a detailed training log
Oh,
and
okay.
plan what you're going to do, and try not to do something that's well out of bounds of what you've done in the last several weeks to several months.
Perfect.
Now, the part B that you're probably thinking is the strength and conditioning program. Um, I think that there's so much benefit and merit to doing that, but because of this complex interaction of factors, it doesn't really seem to me that a strength and conditioning program would significantly reduce injury risk across all running related injuries. It's you know it's part of it's just one small piece of the equation. I do think that from the performance standpoint, there's clear benefits to doing it. We see over the most recent systematic reviews, somewhere between 2 and 8% benefits in running economy with just a concurrent strength and conditioning program. And it doesn't really take that much to do it. It's 2 times a week gets you the benefits, a couple key exercises, and having to be at a certain level of intensity. But I think if we're thinking that something like that is going to reduce injury risk, then our lens of what creates an injury in the first place is probably a little too biomechanical. So the thought is like, okay, well, if my Achilles is going to get injured, I just need to get really strong calves and then it will never get injured. And theoretically that might be true, but it doesn't address the human factors like stress and lack of sleep and time crunches and all that kind of stuff too.
So in fact, that was my answer, was not enough sleep.
Okay.
That
Yeah.
it seems to me that that one of the things is we put so much effort into the what we do category,
Yeah.
we don't think about the what we don't do, and how we need to have that time to recover and really sleeping. I mean, as opposed to, oh yeah, I wasn't running, I took time off, but I only got 4 hours of sleep a night. It's like,
Yeah.
you're surprised you're injured.
That's why 1A is listen to your body.
Yeah, yeah. Okay, Tom Meyer has a question. Tom, why don't you go ahead and unmute and ask your question?
Great, thanks for the talk, Jason. Just at the beginning, you kind of narrow the conversation to running related injuries. And I started to wonder, like, how do I know if some of my injuries are actually running related? Like my back hurts or my neck hurts, or, I have a problem in my toe. Like, how would you, either from a diagnostic point of view or just like generally speaking, like when you talk about running related injuries,
Sure.
how do you connect those two to, like, a lot of things go wrong with the body all the time?
Yeah. So I think there's a consensus definition a few years back that basically has said, at least from the research standpoint, a running related injury is going to be considered something that develops during the course of running or over the course of a training block that then forces somebody to have to alter their training, whether that's from a volume, frequency, or intensity standpoint, for 7 to 10 days or 3 straight sessions or something like that. So basically it has to kind of be something that we think running caused in order for it to be considered a running related injury, as opposed to something that was maybe there that just gets exacerbated by running.
Okay, Sarah has a question, which I think I actually want to chime in on this too, because I've read something about this recently, and we have 2 Sarahs, I believe. This is just, well, I don't know. I'm not sure if it's what it's telling me. If we have 2 Sarahs, this is just Sarah as opposed to Sarah Ridenauer. So, Sarah Drumheller, then please unmute and ask, Sarah.
Yes, hi. I was wondering, Jason, if you could talk some about the emotional impact of being injured and not being able to run, like how to set attainable goals towards recovery and stay positive.
Yeah, that's really tough. And in running, I think more so than a lot of other sports, runners identify with their sport as part of their, that's their person. So they identify as being a runner. That's what they do. And when they can't do it, they lose part of their identity. And I think one of what we know about what runners do when they get injured, based on some survey-based studies, is that they actually tend to do less than what other athletes do when they get injured. Is instead of replacing running with another form of exercise, they tend to just engage in more sedentary behavior. And I think that probably speaks to the, from the psychological standpoint, it's really hard to cope with not having that outlet of your physical and your mental well-being. I think, what I tell people in the clinic, especially the ones that are struggling with this mostly, is we're here now. Let's focus on the modifiable. So, this appears to be the kind of thing at this point that's not just going to go away. So if we're not going to do anything about it, then we're going to stay at this level for a long period of time. And are you okay with being in this state for a long period of time? Most people say no, they don't want to be in that state. And so then you have to set measurable and attainable and realistic short-term goals to really get people motivated or excited about the progress that then happens at that point. And I think it's definitely tougher for some injuries that have a longer natural history or natural time frame of recovery. So some of the tendinopathies that we see in running or complications from bone stress injuries can be years before somebody gets back to full return to competition or where they were at pre-injury. And in my mind, there's no way to do that without seeing that you're continuously making progress and hitting benchmarks. For some runners, it'll be, okay, now that we're restarting this walk run program, we're going to count your weekly minutes spent running, and we're going to do 3 straight weeks where you're going to increase a couple minutes, and then we're going to do this deload week, and we're just going to keep ascending until we plateau. And if and when we plateau, then we'll have a conversation then. But if we don't, then let's keep cracking at it.
So Sarah, I just wanted to recommend a book you might check out. I hope this is not mirrored weirdly. It's called Rebound. And it's written by Carrie Jackson Cheadle and Cindy Kuzma. I know Cindy a little bit. She's a freelance runner who's written for Runner's World a lot. I can't recommend the book completely because it's about athletes of all types who are injured. And speaking as a runner, when I read it, I'm like, yeah, baseball player, yeah, skier who crashed, not to minimize what these people went through, but their problems didn't resonate with me in a lot of cases. And so they have this huge system they want to kind of walk you through and all these exercises you can do and things like that. And I ended up just sort of feeling overwhelmed by it. They also have I can put this in the forum. They have a podcast and I believe a Facebook group called the Injured Athletes Club. And I mean, they're really nice people. They're trying to do a good job and all that. And the only problem, as I said, from my perspective, was that it was not running related enough. It was too broad and also a little bit, actually, I'm remembering this now, a little too focused on elite athletes. So I was like, yeah, you're an Olympic skier and you crashed too many times and now you've got this brain problem and you can't ski anymore. And how's that feel? I'm like, well, it's terrible, but I don't know what that feels like, So any event, we'll share more about that.
And actually, I just kind of was thinking of another thing here is one thing that I'll often do too with the recovering runner is have them kind of treat the recovery process or the return to run process not so much as training for their, for the VO2 max aspect of it, because it isn't at that point. What we're retraining when we're running for 5 minutes at a time, which doesn't feel like running for a lot of runners, is just the ability, the body's ability to tolerate that load again. So I think it's definitely important to contextualize that, unless they're just going to say, all right, well, this PT wants me running 3 or 4 or 5 minutes. They don't really know what running is. You're not going to get as great of a buy-in if that's the case.
I can attest to this, having just done run walk from starting at 1 minute on, 1 minute off. You feel so stupid doing it. Okay. Vade Gunn, do you have a question too? Why don't you unmute?
Sure. Hey, Jason, thanks for the talk. I actually kind of following up on Sarah's question. So I know you talked about expectations in terms of coming back from injury and doing what do you do when you're injured. I guess I have a sort of follow-up in terms of I've been semi-injured, have this issue for a long time where my form has an imbalance, and that's led to an injury that I have right now. And I think it's been going on for 2 or 3 years. It's just kind of recurrent, same symptoms, but nothing completely stopping me from running up until now. So do you have a good idea of, or a rule of thumb for how long until I keep working on my strength and stretching and other mobility exercises to get back to a baseline, for what it's worth, or some idea of getting back to a normalcy?
Sure. So definitely first off, it would be, it hinges on the type of injury. So if what you're describing is a tendinopathy, then it's actually very common for something like that to linger on for several years, especially in higher level runners. I know, if I remember, you were doing some pretty high level running, right? So yeah, with a tendinopathy, it will say that, stick with that as an example. That may be something where we're continuously trying to push that envelope of function up and up and up until the point where all the stuff that we need to and want to do just lies within that envelope. So short answer is yes, keep working at it. One thing that does need to happen though is an appropriate, like I said, with finish your rehab, is the appropriate progression of what is it now that still needs to happen. And oftentimes with a tendinopathy, what gets overlooked towards the end stages of rehab is the ability to produce force quickly and absorb force. So power, plyometrics, those types of programs, those can really take a long time to progress too. Because from a plyo standpoint, it may be even just starting at 5 or 10 jumps and then seeing how the tendon reacts, and a few days later doing the same thing again. And it's poking the body a little bit further down that envelope. Those types of running injuries are usually the ones that are going to take the longest. So our plantar fasciopathies and Achilles tendinopathies. Some other ones though, that, there are a lot of running related injuries we can and should continue to train through, because whether we train or not, it's going to take a certain period of time. So we might as well continue to train. There's no evidence indicating that running before you're completely healed is going to, stop it from happening or elongate the process, save for a few injuries. Those few injuries are ones that are hard stops, which are bone stress injuries. We can't be running through those. And it's debatable whether medial tibial stress syndrome is considered one of those. What we do know about that, or shin splints, is that it actually just still takes really, really long to fix that one if somebody is continuing to run through it. So oftentimes we are better with just kind of let's do a hard pause on this, and let's replace your run training that you were doing otherwise with other stuff. And I think that's another thing that commonly gets skipped, as I alluded to, the runners not replacing their physical activity with something else, is we've got this routine-based mentality. Let's just switch it over to something for a little bit. And then once we're ready to get back to running, we can switch it back to that thing. And maybe if there was something about our training that caused it in the first place that we need to reflect on, then we'll change that aspect of it. But does that adequately answer the question?
It does. I guess my line of thinking was, I didn't really realize it until it became bad. And so for it to get back to normal, I have to keep working on it. And it's going to be, as you said, small steps from plyometrics and strength all the way up to. Okay, that does. Thank you.
All right. Pete Krisak, I don't know if you have babies in lap at right the moment, but if not, you can feel free to unmute and share your story. If not, I will. Okay, so Pete has twins, and he was just saying in the chat that he can attest to the need for sleep for the first 3 months. Oh, is he there? Oh, there he is. Yeah, all right, Pete, tell us.
My wife and I had twin boys back in the end of February, and I took a couple of weeks off from running when we first got started on that, and then we were both off from work for 3 months. So I thought, I have plenty of time to go out and run. So I'll do lower mileage, but make it count and do tempo runs and workouts and stuff. It didn't work too well since I was never able to sleep more than 2 hours consecutively. and I felt like I was just falling apart and never had any energy. So I just scaled it back big time, rather than blow up and have to take like a year off from running.
Yeah, absolutely. I mean, that's, at that point, you're better off taking the time that you were going to be running and just sleeping. That's the healthier thing to do for your body at that point.
I realized that after a few weeks or a month. So it's worked out. Now I'm feeling a lot better now.
Excellent. Okay, Ed Kiefer, you had a comment you wanted to make as well, if you want to unmute and share that. See if Ed's still there. He is.
Yeah. I ended up running for years and years and years as a midfoot striker. I mean, I didn't even think about it, but I ended up going to a biomechanics clinic and in the late 70s, and they were absolutely appalled because I wasn't a heel striker. And so they ended up, essentially saying that you have to do this. And as soon as I end up becoming a heel striker, I end up having like a cornucopia of injuries. And I don't understand exactly why people end up making these decisions to change your natural running style to something that just happens to be the theme of the day.
I don't understand that either. And the sad thing is that the pendulum swung way in the opposite direction. And in the mid 2000s, forefoot striking was the panacea for everything. And the one thing about forefoot striking that actually, so the difference between the strike patterns, all it does is it just loads the lower compartment of the leg differently. So if we land with our forefoot, it's going to load our calf more. And if we land closer to the rear foot, then it's loading our anterior compartment more. The reason why a lot of data shows that forefoot striking reduces loads at the knee and the hip and reduces braking forces isn't because of the part of our foot that's hitting the ground. It's because when you're forefoot striking, you end up taking a shorter stride. And so your foot is landing a little closer to your center of mass. So there's not as much force coming back at you. The thing is, we don't need to change our foot strike pattern to just shorten our stride. So, a lot of the things that I might suggest to an injured runner to try to reduce some forces to keep them running comfortably, increasing their running cadence is one that has the best evidence behind it, because it just slightly shortens their stride, because they have to take slightly, we're talking like 5-10% above their preferred running cadence, and it just slightly shortens their stride, but it doesn't change any other biomechanics, foot strike or anything like that. And that slightly shorter stride just reduces some of the load per stride.
Well, the interesting thing about all of this is that I was a competitive breaststroker, and so I had really huge thighs at the time, and I mean, it sounds goofy, but so naturally I end up taking shorter strides simply because I didn't want to pick the damn thighs up all the time.
It's hard work.
Yeah, but it's funny that if you've been running for a long time, maybe sometimes you end up having a stride that's a pathology, and then sometimes it's something that's actually good for you.
Yeah, I mean, we run in the way that our body self-selects as the most efficient way to run. So that's why largely it should be, if it ain't broke, don't fix it, because our body moves through this path of constraints and it tries to just take the path of least resistance. And there's from a running economy standpoint, that's great because it doesn't expend that much energy. Anytime we make any significant change to our running stride, we become less efficient. And what we just did there then too was we changed what parts of the body were getting loaded. And so if there was previously a structure that was not being loaded very much just from the way that we were running, and now suddenly we switch to this different way of running where we're loading that structure more, that's the spike in workload that I was talking about.
Right.
You can change anything else, and it could be just this spike in, okay, well, we asked it to do something that it didn't have the capacity to do.
Every now and then you see someone who has a truly wacky stride and moves along pretty well. And I always sort of wonder, like, what is it about their body that means that this wacky stride is the best one for them? Because often these are people who actually aren't getting hurt a lot of the time. And
I think there's
quickly.
was it Bridget Jeptu who was a
yeah.
marathon runner? And it's like the classic example of seeing somebody's knees just absolutely knock into each other every stride.
Please. Oh.
So I think Bob Talda is working on a question, but real quickly, you talked a little about stride cadence and possibly trying to increase it. Could you just share a little bit about what you know about the Jack Daniels 180 strides per minute number that we should all obviously be trying for?
Yeah, the 180, it's like at the 1984 Olympics, he looked at all of the runners and just counted their stride rate and found out that basically everybody was running around 180 steps per minute, regardless of their height and leg length, which actually since has become debated because there is actually somewhat of a relationship between leg length and running cadence. But basically he said, well, if all of these people are doing it, then we should do it too. We know from other areas of medicine that that's not necessarily the case, that mentality isn't necessarily the case. So what we know about running cadence is that we have this self-selected running cadence, and that's our most economical way to run. And if we increase it by 5 to 10%, we can change that loading pattern, but it doesn't negatively affect our running economy if we only change it by 5 to 10%. Now that's saying if somebody's at 160 steps per minute going up to 168 steps per minute for a 5% change. So that is kind of what we use. We use running cadence more from an injury rehab standpoint to just temporarily offload certain areas of the body. Naturally, when we run faster, so the running speed is just a product of how fast our stride rate is turning over and our stride length. So if you manipulate either stride length or stride rate, then you run faster. And so for some people, it's going to be more economical or efficient to just increase their stride length. And for others, it'll be more efficient to just increase their stride rate. And there isn't really a great way to determine who is going to benefit other than just try it and see. It's worth noting that you kind of do need a VO2 max testing lab to be able to figure out what your running economy is anyway. So for all of us other folk, we should just see what feels most comfortable and what seems most sustainable. In faster, like middle distance and sprinting, having a long stride length is advantageous. Right. That then comes to this conversation of, well, what's best for performance might not be best for injury risk reduction, because we know that the closer we are to high performance, we're basically just towing the line between what can your body handle and what can it not handle. So that's where it's really important to define what are some of these running things that we're talking about that are good for efficiency and performance versus what do we know is related to injury. The running economy doesn't really seem to be related to injury in any way. So we might as well make ourselves really efficient. That's kind of the end all of running economy.
Good. Bob Talda, have you got your question?
I'm looking. No, you beat me to it. But anyhow, Jason, I could probably do this too. Off the top of my head, on that last slide you had, you mentioned that there were some specific. You can't, for any given case, you can't determine the cause of an RRI. There were some, I want to call them trends or kind of known. Is there a good resource where you could track that or look that up? That's where do you find those? That's more my.
It's a really good question for in terms of like public resources and public education. Yeah. I think the majority of the stuff that I see that are like resources for runners and resources for patients are related to general, the general, what should you look out to do, as opposed to the specific. I mean, from a literature standpoint, there's a lot of places to find the medical literature. I would say if you have specific questions, reach out to me or a running physical therapist.
You can, I mean, Bob, you can also, we have an injuries forum on the site, and that's a great place to ask for that kind of stuff.
I think I was after Adam, as you know from the high noon list, there's sometimes people post articles about this aspect of running or that aspect of running. And it's kind of like, I was wondering if there was more of a clearinghouse or, because it usually spawns good discussions. And so I was looking for kind of a, hey, I'm 60 now. What do I need to be watching out for? What are some of the things I need to be considering kind of things?
Yeah, for that, I would go back to basically just the manage your previous injuries. So take preference to what has bothered you most in the past and has created the biggest impact on your injuries. If there are then specific questions that you have, I think it's I don't know of any really well put together public resource about that.
Okay.
I didn't think there was, but it couldn't hurt to ask.
Yeah. Well, and and some of the stuff, it is just literally a community thing. Someone runs across a great article or whatever, and as you say, posts it, and then discussion happens, and then we loop Jason in, and and it's like, so what do you know about this thing that ended up in this more mainstream publication? So that can be helpful. We have time for one last question, and Vade, take it away.
Sure. Since Bob brought up the correlation between injury and loading, this is a thing I sort of tracked during Philly Marathon 4 years ago when I had way too much time and haven't done since for a marathon cycle. I've heard about acute to chronic ratio, where it's like the mileage you run in a week versus the average of the last 4 weeks. Any thoughts on whether it's relevant? Does it matter? Because I did it in hindsight. I didn't do it actively.
Right. So so there have been 2 studies that have looked at acute chronic workload ratio in runners right now. Both of them have shown that there's no association between injuries. One of them, it was only a secondary measure. So it was kind of just like we'll look at this and just hypothesize based off of that. There's one researcher in Sweden, I think, who's doing his PhD in it right now. I don't expect that we're going to find that it has a significant impact on running related injuries. How acute to chronic workload ratio was originally created was the definition of Homer Simpson walking down the house and just starting to dig into the middle. It was so, and I the guy who created it is a really nice guy, but it's just not how research should be done. He looked retrospectively at these trends in the Australian Football League, and he saw this little curve where there's this window where people were getting less injured, but there are so many explanations as to why that might be the case. And so it's been a really hot topic, but I think it's still just going to come down to don't do too much too soon, whatever too much too soon is for you.
And if it was Australian footy, there was probably beer involved during that.
Oh, definitely.
The one thing I just wanted to add to that I've been playing with recently is the Strava Premium has a relative exertion number, which it calculates based on distance and time and heart rate and things like that, which I've been finding kind of interesting because it really does. I have been watching it change as I get in better shape. The same workout becomes easier. And so just as something that you can like attach yourself to in terms of, am I overdoing it or whatnot, a little bit, just felt a little bit more obvious than that 10% to rule of thumb that's always so frustrating.
Yeah. So one thing that I do think is that's good that came out of all the acute chronic workload stuff is that it actually got people to start taking measures of internal workload. So rating a perceived exertion, just being okay, well, I know that I ran 50 minutes today, but how did I feel on a scale of 10? Because that's really the kind of stuff that fluctuates wildly based on all of the other human factors. And so if we're taking at least one measure of internal workload, and then we're always tracking our other external data, whether it's pace and distance and all that stuff, those 2 things can interact, but it's an arbitrary unit. And that's pretty much what it comes down to.
Yeah. All right. Well, we're at just an hour, so I think we should wrap it up. And for those who want to go back and listen again or check something out, we'll have this posted for people to watch again and online, and spread the word if anyone else wasn't able to make it. I know we had more people signed up than were able to get here at the actual time. But without further ado, Jason, thank you so much for doing this, and hopefully we can do it again on some other topic.
Great. Thanks a lot for having me. Thanks for coming out, everybody.
All right. Bye all.